Spinal cord abnormalities. Under this topic, we will discuss about the compression of the spinal cord, Brown-Séquard syndrome, and chronic myelopathies like Syringomyelia and Subacute combined degeneration of the cord. First of all, we need to know that what could be the cause behind the compression of the spinal cord. It can be either vertebral in origin or meningeal origin or a spinal cord itself, and the mechanism behind the compression of the cord can be either due to the space occupying lesion which causes compression and damage in the nerve, or it can be due to the edema. There are three mechanisms: space occupying lesion, or it can be due to the edema caused by the obstruction in the vein, or due to the ischemia caused by the obstruction in the artery. So these are the three mechanisms behind the compression, and it can be originated from these three sources. Then the second topic is about the Brown-Séquard syndrome. By any means, if the lateral half of the spinal cord is damaged, means only half of the spinal cord portion is damaged in Brown-Séquard type of syndrome. Then chronic myelopathies is divided into Syringomyelia and subacute combined degeneration of the cord. Syringo means, the word syringo literally means that it is a fluid filled cavity, and suppose that a fluid filled cavity is present in a spinal cord, then it will obviously cause compression of the spinal cord. As a result, the nerve within the spinal cord undergoes damage, and the usual site for the fluid filled cavity in the spinal cord is lower cervical or upper thoracic. So these are the two classical sites for Syringomyelia. And subacute combined degeneration of the spinal cord is due to vitamin B12 deficiency, and as we know that during absorption of the vitamin B12, it is necessary that intrinsic factor from the stomach should be present. Suppose that if the intrinsic factor is deficient, then the vitamin B12 will also not be available for absorption, and such a condition in which intrinsic factor is absent, that is called as pernicious anemia. So this is a rough view about all the four topics which we are going to study. Now we will start from the vertebral spinal cord compression. The first origin and the most common origin, that is 80% of the cause originates from the vertebra. That can be and the causes behind the vertebral origin can be either metastasis from the bone, or it can be metastasis from the breast, prostate, or bronchus. Metastasis. Okay, and there can be disc prolapse of disc. Other causes can be any inflammatory sort of disease in vertebra, like tuberculosis or granuloma. So we can write any disease which we remember in the vertebra that can cause compression. The second and the second largest portion is the meningeal origin, that constitute about 15% of the compression causes, and the meningeal causes will be tumor within the meninges. That can be either meningioma or neurofibroma, ependymoma. And there can also be some sort of hemorrhage like subarachnoid hemorrhage, subdural hemorrhage, or any sort of epidural hemorrhage or hematoma. Okay, so these are the meningeal causes. Then and we should also remember that the meningeal causes will cause extramedullary type of syndrome. Extramedullary. We will see that what is the difference between extramedullary and intramedullary, because the spinal cord abnormality will cause intramedullary type of symptoms. So some of the spinal cord abnormality will be meningioma, neurofibroma, or ependymoma or glioma. Gliomas or ependymoma. So these are the spinal cord abnormality. Okay, now immediately after looking for these causes behind the compression, we will differentiate between the extramedullary and intramedullary type of syndrome. And to remember this, we will see the positive finding in the extramedullary type. We can remember it by Krur, C-R-U-R, Krur-Singh का salt, S-A-L-T. So these findings are positive in extramedullary and the salt portion is negative in extramedullary. So what are these? Usually the CSF finding is abnormal in extramedullary. The reflexes become brisk in extramedullary, and the lesion in the extramedullary is usually similar to upper motor neuron lesion. And the next R is for the root pain is very early presentation in case of extramedullary root pain. Okay, and there is sacral sensation is lost in extramedullary, and this salt portion is usually absent in extramedullary. So salt represents that the secondary deficient is very late and rare. Secondary deficient, A is for autonomic abnormality, comes very late, and L is for lower motor neuron lesion, comes late, and the tropical changes in the skin also comes late as a late manifestation. Tropical changes. So how did we learn this? That the CSF is usually abnormal, the reflexes are brisk, but in intramedullary it is usually less brisk, and the upper motor neuron type of lesion is usually early manifestation in extramedullary, whereas it is very late presentation in case of intramedullary type. Then we saw that the root pain is present as a early presentation in extramedullary, and sacral sensation is usually lost very early sacral sensation. The secondary deficit syndrome is usually not present or maybe very late presentation of secondary deficit. There is usually no association. Okay, and autonomic involvement is late, and the opposite is applicable for the intramedullary. Lower motor type of lesion is very late presentation or may not be present even, and the tropical changes are usually not present in case of extramedullary. So we saw that the Krur-Singh is present in extramedullary, whereas the salt is absent in extramedullary. So after comparing the extramedullary lesion with the intramedullary lesion, we will proceed to the management of the compression. So for the management, we need to diagnose the compression of the spinal cord, and usually the diagnosis is done. And speaking about the manifestation, usually the clinical presentation of this patient difference lies according to the site of the cranial nerve, spinal nerves. Okay, if suppose that the lesion is above C5, then usual presentation will be paralysis, quadriplegia, paralysis of both upper and lower limb, quadriplegia, along with weakness in the diaphragm, means respiratory problem will also be present. And if the lesion is in the region of C5 to C7. Then usually the hand portion we will divide it into what happens in hand and what happens in leg. Then the usually hand is hand में क्या होता है, तो लोअर मोटर न्यूरॉन लेजन का फीचर आएगा, and the leg presents with upper motor neuron lesion. And as we know that the presentation of the upper and lower motor lesion we have already discussed about this. Then if it is of thoracic region, then usually it affects the leg portion, means there will be loss in sensation as well as weakness of the leg, and there will be leg pain also. And the lumbar and cauda equina portion of the suppose that it is a lumbar in origin, then lumbar if the lumbar origin it is of L1 L2, then the cremasteric reflex is affected. L1 L2 region में cremasteric reflex, L2 L3 में paralysis of the flexion and abduction of the thigh, L2 L3 में flexion and abduction of thigh is lost, abduction of thigh is lost. And if it is of L5 S1, then the movement of the foot and ankle is lost, foot and ankle movement is lost. So this is about the clinical presentation according to the site involved in the spinal cord. So for the diagnosis, it is very easy to diagnose a spinal cord compression patient. We will send the neurological examination like MRI of spine, and we can also send plain X-ray of a spine. X-ray can be sent, and we can perform myelography for the muscle and spinal cord examination. Myelography, EMG can be performed, electromyography, and CSF, we should also perform the CSF examination to rule out any infection present and usually we can find that there is raised protein causing yellow discoloration of the fluid, and some of the peripheral polyneuropathy should also be ruled out by looking the vitamin B12 level, whether it is deficient or not, and biopsy should be sent in case of any suspected tumor. So this is about the diagnosis of the spinal cord compression. And as we saw that there are a lot of causes behind the spinal cord compression, so the management or the treatment procedure also varies according to the cause behind it. Suppose that it is due to any metastasis or due to any glioma or tumor, so we should undergo for the surgical treatment. So the malignancy should be surgically removed. If it is due to the hemorrhage, then accordingly we should treat. So we should remember the causes, and accordingly we will proceed for the management. So now the second topic is about the Brown-Séquard syndrome. And Brown-Séquard, as I said that Brown-Séquard syndrome is usually one-sided damage, and that is usually lateral half of the spinal cord, and which causes a band of pain at the level of the lesion. जहाँ पे डैमेज हुआ है वहाँ पे पेन होता है, और the cause behind the Brown-Séquard syndrome is usually penetrating gunshot or tumor. The cause is penetrating trauma, or it can be some tumor. So the actual thing which we need to remember in the Brown-Séquard is the clinical presentation of the Brown-Séquard syndrome, and it is divided according to the suppose that we can divide it by what happens at the level of the lesion, what happens above the lesion, at the level of lesion, and below the level of our lesion. So above the lesion usually it is normal. So this is already finished. Now what happens to the level of the lesion? At the level of the lesion, the feature is similar to that of lower motor neuron lesion, and we should know that what happens in at the same side में क्या होता है, and what happens in the opposite side. So on the same side there is loss of all sensation. All sensations are lost except that of pain and temperature. Except pain and temperature. Whereas in opposite side there is loss of only pain and temperature. Loss of pain and temperature. What did we saw at the level of the lesion? We saw that at the level of the lesion the clinical presentation is usually similar to the lower motor neuron lesion, and at the same side there is loss of sensation. All sensation are lost except that of the pain and temperature, whereas in opposite side there is all the sensation are present except that of pain and temperature, means there is loss in the pain and temperature. And what happens below the lesion? So below the lesion usually at the same side there is loss in the touch and perception. Proprioception means on the same side what is lost? That is touch and proprioception. Whereas on the opposite side there is slight motor paralysis, not complete paralysis but slight motor type of paralysis is seen. So we need to remember only at the level of the lesion and below the level of lesion. At the level of lesion usually all the sensation are lost in same side, whereas pain and temperature only are lost in opposite side. Below the level of lesion on the same side touch and proprioception is lost, whereas in opposite side there is slight motor paralysis. So this is the thing which we need to remember in the Brown-Séquard syndrome. Then the last portion is about the chronic myelopathy, and in this topic we are going to study about Syringomyelia. As I said that the word syringo means there is fluid filled cavity within the spinal cord. This fluid filled cavity is within spinal cord, and Syringomyelia is cavitary expansion, causes the cavitary expansion of the spinal cord, and usually it is the classical site for the Syringomyelia is at the level of lower cervical region or upper thoracic, and this ascends upward. One should always remember that the fluid ascends upward. Okay, and towards the medulla and pons. Medulla and pons की ओर ये ऊपर चढ़ता है, and the pathogenesis is usually, look, the second important thing in Syringomyelia is about 50% of the Syringomyelia is associated with Arnold-Chiari syndrome. It is called as Arnold-Chiari syndrome, and Arnold-Chiari syndrome is the cerebellar tonsillar herniation via the foramen magnum. This is cerebellar tonsillar herniation. Cerebellar tonsil gets herniated from herniation from the foramen magnum. So this is the this feature. Usually the Syringomyelia is associated with Arnold-Chiari syndrome, and there will be, which allows the normal pulsatile CSF pressure wave to be transmitted to fragile tissue to the cervical spinal cord and brain stem, and as a result there will be secondary cavity formation in the spinal cord, and progressively that cavity formation will cause degradation in the spinothalamic neuron. There will be degradation after the cavity formation, and this degradation will cause chronic type of myelopathies. So it is considered in the as a chronic myelopathy, and a classical presentation is central cord syndrome, which is dissociated sensory loss and areflexia, weakness in the upper limb. Means how do they present? Usually the Syringomyelia present with the feature of motor, sensory and reflex all becomes normal. There is weakness in the upper limb. Upper limb में motor abnormality, sensory paraesthesia is seen, and reflex are absent. So this is the presentation, and for the investigation we sent MRI scan of the spine, and usually surgical treatment is required. The treatment is surgical. And posterior compression of the Arnold-Chiari malformation and thicoperitoneal shunt may be needed to drain the cavity. Means the treatment is usually surgical and the diagnosis is via MRI. And as we saw that the subacute combined degeneration is usually due to the vitamin B12 deficiency or pernicious anemia, and they present with the sensory loss. Means there is paraesthesia of hand, feet, and vibration and position sensation is also lost. Vibration, positioning are also lost, and reflexes are also lost in such a patient. And the myelopathies of subacute combined degeneration tends to diffuse rather than becoming focal. Okay, usually these features are diffuse type. And optical atrophy and irritability become prominent in advanced cases. In late cases there is optical atrophy. And for the diagnosis we will see for the vitamin B12 deficiency, and in this way we can diagnose. And CT, MRI of spine is also sent, spinal cord, in which there is inverted V sign or rabbit ear sign. Look, here is the MCQ portion, that is inverted V sign is seen, also called as rabbit ear sign. Okay, this is the sign which is present in SACD. And for the treatment there will be replacement therapy beginning with 100 mg intramuscular. The treatment is 100 mg IM vitamin B12 replacement. So we saw that in Syringomyelia there is loss in the motor, sensory and reflex component, whereas in B12 deficiency there is sensory loss causes paraesthesia, vibratory loss, positioning loss and reflex loss in late stages. And usually these all features are diffuse in nature, and in late phases you can also find optical atrophy along with irritability. And for the diagnosis you send to estimate the amount of vitamin B12 along with MRI, and MRI will show you inverted V sign or rabbit ear sign. And for the treatment we will go for the replacement therapy for of the vitamin B12, usually started at the dose of 100 mg IM of the vitamin B12.